Good evening, all the aspirants present here. So, today the topic is oxygen therapy, and the speaker we have here is Dr. Asif Iqbal, who is a senior consultant, Department of Respiratory Critical Care and ECMO Services at Apollo Hospital, Kolkata. And we have the moderator here is Dr. Tapash Sahu, who is a Associate Director and Head of the Institution of Critical Care and Anesthesiology in Vedanta. Also, we have Dr. Banambar Ray, who is HOD in Critical Care Medicines at
I'm
From
interrupting.
Ultimate Medicare,
Sana,
Bhubaneswar. So, Asif Iqbal sir, you can start the class.
good evening, Tapos
Good evening. Good evening. Good evening, Dr. Asif. Thank you. Thank you for inviting, and we can start. Yeah.
Thank you. So today class is oxygen therapy, and this is for all IDCCM, DRNB, and the DM student because it is a very hot topic. Those who are working in the critical care area. So today I will restrict my oxygen therapy class on regular oxygen therapy and the high flow nasal cannula because oxygen therapy is include your ancillary device, also your HFNC, NIV, and the ventilator. So we will restrict our class on the ancillary device and the HFNC. So before going to the oxygen therapy in details, you have to know what is hypoxia and what is hypoxemia because this question is a very famous question to ask for the examiner to student. So remember hypoxia means when there is a low PaO2 or partial oxygen pressure in the blood, and hypoxia means hypoxia occur when oxygen supply are insufficient to meet oxygen demand in particular compartment like in the tissue hypoxia. So again, hypoxia is a four type: histotoxic hypoxia, anemic hypoxia, stagnant hypoxia, and hypoxic hypoxia. Histotoxic hypoxia means the tissue inability to take up the oxygen from the blood in a normal cell for normal cellular metabolism. Anemic hypoxia means when there is a hemoglobin percentage is very low and therefore the blood oxygen content itself low. And stagnant hypoxia when there is a the blood flow is inadequate, so there's stagnation is there, therefore the low level of oxygen in the tissue level where the blood stagnation occur. And hypoxemic hypoxia is when the truly oxygen is not available, so oxygen content in the blood again low due to reduced oxygen content. Oxygen delivery system, there are 10 type of oxygen delivery system. Ancillary oxygen delivery system, that is nasal cannula, simple masks, partial rebreathing masks, non-rebreathing masks, venturi masks, oxygen hood, oxygen tent, ambu, tracheostomy collar, or TPs. So, if you classify those who are anesthesia background, you know that in practical exam, there is a table for oxygen therapy where the question has been asked about the low flow system and the high flow system. Low flow system is contribute partial to impaired breathing of patient, and it flow is less. It's nasal cannula, simple marks, non-rebreathing marks, partial rebreathing marks. High flow system is delivered specific and content percentage oxygen independent of patient breathing, like Venturi marks, TPs. These all are, and also HFNC is a part of the high flow system. So nasal cannula, you all know the nasal cannula is a very useful equipment for a patient, and it provides the oxygen as well as comfort to the patient, and it used when the patient is on, suppose patient are eating or patient, it give comfort to the patient. But the disadvantage is FiO2 supply is very less, and you can continue the oxygen up to 4 to 6 liter maximum. And the advantage is easy to use, home setting, safe and simple, easy to tolerate. But disadvantage is unable to use in the if there is a nasal obstruction, and it cause drying of the mucous membrane, can dislodge easily. No good. Those patients who are mouth breather is not good for them, and patient breathing pattern affect exact FiO2. Now coming to the face masks, there are different type of face masks: simple oxygen masks, partial rebreathe masks, non-rebreathe masks, and venturi masks. Now coming to the simple oxygen masks, which is used in the ward, uh, it has a port, and it can give flow maximum 5 to 10 liters, but it give maximum FiO2 up to 50 to 60%. Advantage, it can provide increased delivery oxygen in a short period of time, but due to there is open pore, the FiO2 get diluted, so it cannot reach more than 60%, and uncomfortable for the patient when patient eating, talking, and not suitable for type 2 respiratory failure. And another advantage, if there is a secretion in the mouth, then it can be easily identified. Partial rebreathing marks, there is a port is there, simple marks with port is there, but there is a valve. So this valve, when there is an inspiration, it stuck in the port. So during inspiration, concentrated FiO2 enter the system, and when exhale, the valve is open, so therefore it is called partial rebreathing, and it's give up to 80% of oxygen delivery. But you have to when you are using partial rebreathing mask, you have to keep the flow little higher side, at least 6 liter per minute. And the advantage, client can inhale room air through open it, max oxygen supply briefly interrupted. Disadvantage, require tight seal, and it is during talking, eating, it is again difficult like your simple marks. Non-rebreathing marks, these marks provide highest concentration of oxygen. Non-rebreathing marks means there is no chance of rebreathing. In partial rebreathing, there is a chance of little bit exhale fresh air, but it is sealed such a way that when you are taking deep breath, this peak flow, the extra air is getting for the reservoir bag. So there is there is a supply of 100% FiO2, and usually you have to give at least 10 liter of flow, 10 liter per minute flow, and you have to have the reservoir unit is full and open, and the valve is one way type. When you will exhale, there the valve is open. When you inhale, the valve will be closed. So advantage, obviously it gives maximum possible FiO2 is close to 100%. Disadvantage, impractical for long-term therapy, and malfunction of the valve can cause CO2 buildup, suffocation. It is usually expensive and uncomfortable. You can see this. You can see this. Yes, just a minute. You can see this rebreathing marks where there is a valve and there is a reservoir bag. And when there is a partial rebreathing system, there is a chance of partial rebreathing due to opening of this valve is not 100% closed, but this valve is 100% closed. Then another type of marks is called Venturi marks. You see that Venturi marks, there is a different color coding, and this different color coding is for the FiO2, different FiO2. You can provide the different FiO2. This Venturi marks works on the Bernoulli principle. Bernoulli principle, what is the Bernoulli principle? When the flow of gas or liquid in a particular very small narrow place, it causes the negative pressure in the bottom of the area, and this negative pressure suck the normal air. So it causes the dilution, and according to the dilution and according to the diameter of the opening plot, it give the concentrated oxygen. So it can give you the fixed FiO2. So it is morely we use in a COPD patient when there is a type 2 failure patient or COPD patient in a recovering phase. We use the most important thing is the supply precise oxygen concentration and does not dry mucous membrane. Disadvantage uncomfortable and risks of skin irritation because flow little higher. And the oxygen hood usually used in a pediatric patient. You have already seen the picture. And hood is usually plastic made, and it supply warm, moist oxygen, and it give a comfortable oxygen supply to the patient. And sometimes oxygen tent you can use, but it is used more on the pediatric ICU and neonatal ICU. Ambu bag, I think you all know that Ambu bag, but it is actual name is rebreathing, self-inflating rebreathing bag. Ambu bag is name given by the company. It has few component. One is the reservoir bag, tubing, marks, and there is a special valve, and this is rebreathing unit. So it help in during resuscitation, during intubation, and also you have to keep this ambu bag in your ventilator side when there is a desaturation. So first you have to think that whether the machine is equipment is working good or there is a kinking or not. So in emergency situation, you can you can remove the ventilator and you can start ambuing in your patient. So you always keep one ambu bag at bedside of your patient. The tracheostomy collar or tracheostomy marks. So this is a special marks for a tracheostomy patient. When the patient tracheostomy, we do tracheostomy for different indication. Sometime for patient in a long-term ventilation, weaning difficulty, we do tracheostomy. And this special marks can be used, or tracheolite can be used. And TPs, usually TPs we use during weaning from the ventilator, but nowadays TPs trial is not very popular method for weaning. Nowadays we do pressure support ventilation rather TPs trial because TPs trial has there are certain problem, especially in it causes the atelectasis in the base of the lung. Now coming to the determinant of FiO2 with oxygen supplement during BiPAP. So when you are using BiPAP, how will you calculate the FiO2? There is a trial showing that when the oxygen flow will be liter per minute, 0 to 16 liter per minute, and the IPAP is you are giving 2, 8, 12, 16, 20. The according to the inspiratory pressure, in particular liter per minute, the FiO2 little change is it depends on point where oxygen is added into the circuit and the level of inspiratory positive airway pressure and the oxygen flow rate. It does not depend on the respiratory rate and the tidal volume. So when you are using BiPAP, so what will be your exact FiO2? Is three factor. One is the flow, one is the positive pressure, and point where you are giving oxygen at the near the marks or near the end of the ventilator. There is another trial showing that there is no significant difference between oxygen concentration achieved either route at any flow rate. Average mean FiO2 for both routes. So if 1 liter oxygen supply approximately 31% oxygen the FiO2. So the another trial showing that it is not on the where you are keeping, but it is depend upon the flow rate and your IPAP rather the position. Now coming to the high flow nasal cannula oxygen therapy in adult. First time we found the maximum positive article after 2015, but it is initiated from 2003 onward. The introduction purpose of respiratory support to maintain adequate ventilation and the oxygenation. So it can currently it ensure that adequate alveolar ventilation, minute ventilation is manipulated during invasive and NIV support. So the high flow nasal cannula oxygen delivery has been going attention on alternative means of the respiratory support. It can be used in the what is the advantage of HFNC, that when we are using a rebreathing, I have already mentioned the rebreathing, though we are giving the nearly 100% oxygen, but there is a lot of disadvantage of this marks. And there is a lot of advantage of the cannula, but nasal cannula, but in the nasal cannula, the major disadvantage was that we can't give more FiO2 or more flow to the nasal cannula. So to overcome the non-rebreathing box problem and to introduce the nasal cannula's advantage, made this HFNC, and it is alternative conventional oxygen delivery for hypoxemic patient. HFNC oxygen therapy has been received more and more attenuated. Here you can increase flow up to 60 liters and 30 to 100 liter per minute, and you can achieve FiO2 up to 95%. So 95 to 100%. The HFNC, this is the HFNC. HFNC has the oxygen blender where you can give the oxygen to maintain certain FiO2. Then there is a active heated humidifier here. So humidifier which make the humidified oxygen to prevent the dryness in the mucosa, and there is a single circuit and the nasal cannula. So you can provide FiO2 0.20, 21% to 100% and flow up to 60 liter. Gas heated humidified by active humidifier, which cause less discomfort, less injury to the nasal mucosa. Interface in NIV increase anatomical dead space, but in HFNC it decrease anatomical dead space. HFNC cannot actively enhance your tidal volume, but it can give you the comfortable oxygen supply. And there is a lot of controversy regarding whether we will use in the COPD patient or not. But the newer trial coming and showing that it can be used in the COPD with a good result. But the definitely we can use in a type 1 respiratory failure, and especially post-extubation patient or patient with a mild to moderate ARDS patient with pneumonia. So, and also patient with hypoxemic respiratory failure, sleep apnea patient, heart failure patient, we can use. Physiological effect, high flow adequately heated humidifier get considered to have number of physiological effect. One is it causes PEEP effect, which help to open the alveolar and so lung recruitment little bit, and constant fraction of inflow oxygen. Sana, please look at mute this thing. So and reduce anatomical dead space. That is another advantage. And how it's reduce anatomical dead space by it has been shown that it found that tracheoabdominal synchrony is better with HFNC than the face mask delivery. And since the tidal volume is a fixed, so its breathing frequency is reduced by minute ventilation. So when there is a respiratory rate is lower, it causes low minute ventilation. It also been report it evidence suggests that there is a less dead space. Another trial published in 2005, Wetsin et al. Compare FiO2 in healthy volunteer breathing with mouth open and closed. So they have seen that when when the patient has open mouth, doing HFNC and doing breathing, they have a good FiO2, and nasal oxygen enter and contribute higher FiO2 compared to close mouth volunteer. And PEEP effect, Sana, please mute.
Dada.
So PEEP effect, although delivered through an open system and a high flow, overcome the resistance in expiratory flow and create positive nasopharyngeal pressure. And Park et al. Measured the nasopharyngeal pressure in post-cardiac surgery patient, compare HFNC and face mask delivery. They found that nearly about around 5 PEEP develop in a HFNC when the flow is 35 to 40 liter per minute. Then coming to the author have also reported that positive foreign pharyngeal pressure with HFNCs affected by gender, body mass index, mouth closed or open, and the flow rate. Another two trial on the positive pressure that it has been shown that Riera et al. Also measured the supine or prone posture and expiratory lung volume is electrical lung impedance tomography showing that there is no much changes than with the position and with the position of the patient. And regarding the FiO2, they are showing that if the oxygen flow rate is 1 to 6 liter per minute, the calm breathing showing reaching the FiO2 is 0.26 to 0.54, where rapid breathing showing 0.24 to 0.45, where if it is given the 6 to 15 liter per minute, then calm breathing is 0.4 to 0.5 to 0.7. So if the patient has rapidly breathe, then there is FiO2 is lesser than who are doing the physiological breathe. And Richard it also shows that the HFNC rest and exercise, so delivery FiO2 gas flow rate, and when the high peak inspirator flow rate with exercise associated with increased air enter through the resulting load. So if the peak flow is very high, then the FiO2 depend on your the flow rate. So if the patient has high peak flow, high respiratory rate, then you have to add to achieve the desired FiO2, you have to keep the flow rate higher than the normal. Okay. So with FNS, especially high flow, actually FiO2 is close to calculate predictor FiO2. So if you want to achieve high FiO2, then you have to keep the flow also higher side. Now coming to the humidification, the conventional oxygen delivery system, we do not have the active humidification system. Therefore, it causes discomfort, nasal dryness, oral dryness, and eye irritation. But in HFNC, there is a active humidification is there. Therefore, it improve the humidification, which ultimately improve your mucociliary function, facilitate clearance of the secretion. It associated with less atelectasis, minimize airway constriction, and reduce work of breathing. And the Chikta et al. In 2014 in respiratory care journal, they published that found that regardless of patient VT or minute ventilation, HFNC deliver adequate warm humidified gas when gas flow is greater than the 40 liter per minute. Now coming to the clinical uses of HFNC. So it can be used hypercapnic respiratory failure, hypoxic respiratory failure, especially in post-extubation patient when where there is a doubt whether this patient may re-intubate. So to prevent re-intubation and pre-intubation oxygenation in a ICU, in a obstructive sleep apnea patient. During the bronchoscopy shoot, we regularly use during EBUS, endobronchial ultrasound procedure, or tracheal stenting procedure, we regularly use HFNC, and it helps to prevent intubation. And when there is a contraindication of NIV or patient is not tolerating NIV, you can use HFNC. Now coming to some clinical trials. So hypercapnic respiratory failure, we know that hypercapnic respiratory failure, if you give the more oxygen, it causes detrimental. But in 2014, Minar et al. Have reported successful use of HFNC oxygen therapy to manage hypercapnic respiratory failure patient unable to tolerate conventional NIV. So, hypercapnic respiratory failure, always NIV is first choice, but if the patient is not tolerating NIV, HFNC can be your alternative. There another clinical investigation paper, effect of nasal high flow on ventilation in volunteer of COPD and idiopathic pulmonary fibrosis patient. And the objectives describe change of respiratory parameter and method they use pressure amplitude during the respiratory cycle, mean patient in healthy volunteer and patient IPF and the COPD are measured. Polysomnography devices used to measure the tidal volume and minute ventilation ABC before and after uh, 8 hours of breathing. So what result come? It result increase pressure amplitude and mean patient in healthy volunteer, also in COPD and IPF comparison with spontaneous breathing, and in COPD case increase VT, no difference the tidal volume in IPF patient, and in healthy volunteer it shows that VT little decrease, but respiratory rate and minute ventilation were reduced in all the group, and capillary PaCO2 decrease patient with IPF and COPD. So in this study conclusion, HFNC did a significant effect on the respiratory parameters, especially in COPD or restrictive, obstructive or restrictive pulmonary disease. CO2 washout effect in upper airway part is due to anatomical dead space reduction and beneficial effect of HFNC instrument. So maybe it help on CO2 wash out. One is reducing the dead space, and second is it effect on PEEP effect on the lungs. It help in opening the airway. So another study, nasal flow versus non-invasive ventilation in a stable hypercapnic COPD preliminary report. This is multidisciplinary respiratory medicine journal, and it's showing that the stable hypercapnia and exacerbation free time is 6 weeks in a stable patient when you are using the HFNC. And demographic data, the FEV1 by FVC ratio is 45%. So this is a moderate to severe category of COPD patient. In first 6 weeks, NHF system 20 liter per minute with supplementary oxygen. Next 6 week patient with NIV, the patient introduced use of device more than 5 hours per day, maintain stable oxygen supplement. And what result we found, the 6 week when the HFNC lead to significant decrease or resting CO2 after decreasing HFNC therapy, NIV was able to preserve normocapnia, and no difference PaCO2 were observed between two methods. So then author postulated that this NHF decreased PSU despite of reduce your minute ventilation reduction hypercapnia demonstrated is able to affect alveolar ventilation, and using NIV normocapnic was stabilized. One could speculate that NIV is able to decrease capillary carbon dioxide with the same. So the conclusion is HFNC may thus be alternative treatment device stable hypercapnic COPD patient. So in stable hypercapnic COPD, we know that when the patient has developed called pulmonera, this patient need domiciliary oxygen therapy. So to reduce the exacerbation in this group of patient, HFNC has a good role. And now coming to the hypoxic respiratory failure. So there's the original trial, intensive care medicine 2011. The beneficial effect of humidified high flow nasal oxygen in critical care patient and post-operative pilot study. And this study is monocentric, 38 patient. The ARF more than 9 liter per minute, oxygen to acid SpO2 more than 92%. Baseline demographic and clinical data, as well as respiratory variable, both the group has HFNC initiated during first 48 hours were recorded. ABG before and after HFNC therapy, and noise and discomfort are monitored along the outcome and need invasive mechanical ventilation. In this trial, it has been found that HFNC significantly reduced respiratory rate, heart rate, dyspnea score. Respiratory rate and SpO2 improved as early as 15 minutes with HFNC. 1 hour after HFNC significantly improved PO2 and PO2 FiO2 rate, ratio. And it was never interrupted for tolerance. No nosocomial pneumonia occurred during HFNC. So it has been shown that the dyspnea is reduced, respiratory rate, and thoracoabdominal, the more important thoracoabdominal asynchrony reduced with time, and the pulse oximetry is showing that it improved the saturation. and also heart rate is improved. So in conclusion, HFNC has beneficial effect, clinical sign, oxygenation in ICU patient in acute respiratory failure. This favorable result contribute prerequisite launching of the RCT2 investigation. HFNC reduce intubation in this group of patient. Now coming to your another is the impact of high flow nasal cannula oxygen therapy on intensive care unit patient with acute respiratory failure. This is a prospective observational study, and in this prospective observational study, acute respiratory failure despite oxygen on a conventional face mask or their indication for immediate intubation treated with HFNC oxygen. Clinical respiratory parameter ABCU are compared under conventional or HFNC oxygen therapy, and total 20 patient aged is around 38 to 75 years, and SAPS-2 score was 33 and were included in the study. And etiology of acute respiratory failure is pneumonia, sepsis mainly. And the result found that in conventional oxygen therapy and HFNC, significantly respiratory rate reduce, SpO2 improve, and PaO2 improve significantly, and the PaCO2 is as compared in both the group. So in conclusion, use of HFNC patient with persistent acute respiratory failure associated with significant and sustained improvement, both clinical and biological parameter. Another study published in the 2015 high flow nasal oxygen HFNC in acute hypoxemic respiratory failure, that is called Pluralis trial, and it has been it included more than 18-year age group of patient following criteria: those who have respiratory rate more than 25, PF ratio less than 300, and PaCO2 is more than 45, or absence of clinical history underlying chronic respiratory failure. And then total 313 randomized patient group in three group, and it has a primary outcome was proportional patient intubated in day 28, and secondary outcome is all case mortality ICU, all cause mortality at 90 days, and ventilation free days in 28 days. So intubation rate in HFNC group 38%, in standard group 47%, NIV group is 50%, and ventilatory free day at day 28 HFNC is 24 plus minus 8 days, standard group 22 plus minus 10, NIV group 19 plus minus 10, and all are comparable. So hazard ratio for death at 90 days, standard oxygen versus HFNC is 2%, and p-value is 0.046. NIV versus HFNC is 2.5 is comparable. In conclusion, there was significant difference in favor of high flow nasal cannula in 90 days mortality, and patient with non-hypercapnic or acute hypoxic respiratory failure treatment with high flow oxygen with the standard oxygen therapy or non-invasive method did not result significantly different regarding the intubation rate. So there is another, there is another study on the post-extubation. So there are two trial. One is MODERATOR published and one is Park et al. Published. They compare the delivery via Venturi marks and the HFNC on oxygenation and clinical outcome. And they see the PF ratio and the re-intubation rate. And it has been shown that the oxygenation was found between two group is good, but significantly fewer patients require escalation of the respiratory support is HFNC group. And the operator comprises an early nasal high flow oxygen therapy with standard care prevention post-operative hypoxemia after abdominal surgery and study protocol for multi-centric randomized control trial. And they do the pre-intubation oxygenation through HFNC, and showing that pre-intubation oxygen therapy with HFNC reduce the prevalence of severe hypoxemia and improve patient safety during intubation. And obstructive sleep apnea patient and stroke and the OSA stroke patient with abundant CPAP owing to discomfort. It has been reported that HFNC was well tolerated and decreased the hypoxic index and oxygen desaturation index, and the percentage of slow wave sleep significantly increase in quality of the sleep was better with the HFNC group, and HFNC therapy is variable in acute stroke patient. Now coming to the acute heart failure, there is a Moraima et al. Successfully maintained oxygenation in a patient with life-threatening reperfusion pulmonary edema, which arose after transluminal pulmonary angiography by applying for 3-day HFNC FIO to 100%, 50 liter per minute. It's a case report in 2014. And in a bronchoscopy, there is a lot of trial on the bronchoscopy showed that during bronchoscopy, if you use HFNC, it can reduce the desaturation, it can reduce the intubation rate and also the bronchospasm. And in a do not intubation status, you can use HFNC in a DNI and a hypoxic patient. It give better oxygenation and it give better comfortability. Now coming to the contraindication of HF, when there is a contraindication of NIV, you can use HFNC. So what are the contraindication? One is the consciousness. If the patient is not cooperative, not conscious, not oriented, or patient with agitated, uncooperative, you can't use NIV, where you can use the HFNC to prevent the hypoxia. And airway obstruction patient, or there is a facial injury and facial malformation, you can give the HFNC. And patient with a lot of sputum secretion, risk of aspiration, and unstable hemodynamics, this patient you may give HFNC, but in a shock patient, intractable arrhythmia, post CPR patient, the NI it is better than the it is contraindicated for NIV. So effect of post-extubation HFNC with NIV or HFNC alone on reintubation among patient with high-risk extubation failure. This trial showing that reintubation rate after day 7, the HFNC alone is lower than the HFNC with NIV. So proportional patient post-extubation respiratory failure day 7 comparable with HFNC and the NIV. And reintubation rate until ICU discharge, there is a significant difference between HFNC and the NIV. So in conclusion, HFNC oxygen delivery is proving to be value add and has been gaining attention to alternative measures for respiratory support in critically ill patients. It seems to be effective in treating hypercapnic respiratory failure, mild to moderate hypoxic respiratory failure patient, and some important issues such as indication of HFNC and criteria of timing to start HFNC for stopping HFNC escalation therapy remain to be resolved. Now there is a lot of scoring system has come to know where when you will consider that the HFNC failure and this patient need intubation early. I have not included this slide, but you can predict. But as a whole, the HFNC uses of HFNC in your ICU to prevent mild, moderate ARDS patient. It helps to prevent intubation. Thank you. Thank you for patience hearing.
Thank you, sir. It
Super.
was a very informative session. And also, thanks for your presence, Dr. Tapas Kumar Sahu, sir.
Thank you, Dr. Asif. I would be adding two, three things. You have
Yes.
nicely narrated everything in almost 1 hour class. I'm not going to add anything more. But as the candidates, as the trainees, they should be knowing about few trials that can be asked in their exam. One is florally trial, one is hot ICU trial, and one is loco 2, which is like comparing between conservative versus liberal oxygen strategy. Right. So these are the trials that you need to know. That is one thing. Then HFNC can be also used in the prone positioning in hypoxemic respiratory failure to improve the ventilation perfusion matching. So that is one thing which you can integrate with the other modality like HFNC plus prone positioning. And the future is also like there are few other things are also coming up related to HFNC. Maybe if you are answering very well, so the examiner would be asking you to like how HFNC can make your personalized therapy or for the oxygen delivery in some of the selected populations, like in obese patients, in pediatric patients, then in immunocompromised patients. So that those are the things which are coming up in a like no little bit of elaborative way. And then definitely the examiner would be asking you the comparison between HFNC and NIV, and Dr. Asif has clarified very well the HFNC and NIV. But one important thing always the examiner asks, what are the oxygen targets in specific population groups? Like they would be giving you idea of like no post cardiac arrest, what should be your oxygen target, SpO2 target, in traumatic brain injury, in ARDS. So because like no, the situations will vary and the SpO2 targets will also vary. So it's not always right now what we are targeting 98% or one like 100%. The ideal oxygen target saturation target is always around 90 to 94% in critical ill patients, because liberal oxygen therapy would be increasing hyperoxia and also associated oxidative stress and hypoxia if you are giving the less oxygen therapy. So these are some of the my viewpoints, and the rest of the things have been clarified by Dr. Asif. Thank you very much for inviting me.
Just one request, if you can tell them the about the hot trial, because I know I had learned your lecture in Bhubaneswar regarding the hot trial.
Yes.
A few silent points regarding the hot trial and the liberal oxygen therapy.
Yeah. So hot ICU trial is actually comparing. I'm just like no giving you the exact the trial design. Just give me. I have the presentation with me. Hot ICU trial. So because as you have told, and this is a very important trial which is like comparing. I'm just giving you. Yeah. This is a trial which has actually described handling oxygen targets. The hot H for handling, O for oxygen, and T for targets. So hot ICU trial is a multi-center randomized control trial that has been published in NEJM in 2021, and it investigated conservative versus liberal oxygen targets in adult ICU patients with acute hypoxemic respiratory failure. Now the objective was they compared between lower oxygen target SpO2 90% compared with higher oxygen target SpO2 96% in critically ill patients receiving oxygen therapy. And it's a multi-center randomized trial with almost 3,000 patients. And patients were like divided between lower oxygen target with SpO2 around 90%, PaO2 of 60 versus PaO2 90 with SpO2 96. And the primary outcome was 90-day all-cause mortality. So this is something very interesting. They have actually tried to keep mortality. But the finding was there was no significant difference in 90-day mortality between lower and higher oxygen target. That means a lower oxygen target is as safe as higher target for critical ill patients with acute hypoxemia. So what is the conclusion and what is the implication for our practice? Overly liberal oxygen strategy may not improve outcome. Rather, it can cause hyperexia related harm. So individualizing oxygen target with SpO2 around 90 to 94% is as safe, and it avoids unnecessary oxygen exposure. This is something very important message they tried to provide, that you should not be trying 96%, 98% in ARDS patients also. So this is something very interesting published in NEJM.
Thank you, Tapusda. So, student Sana, we can conclude.
Yes, sir. So it was a very informative, very insightful session, and we liked you today. Thank you.